Because like here I can unmute all, but I want to keep them muted. I can't unmute him.
I wonder if he doesn't have the audio on his computer.
But we've done it before. He does. Well, should I? Hello? Yeah. Right. Great. Okay. Okay, I can do that. And then you'll introduce him. Okay. I'm trying to figure out, yeah. Okay, great. I'm on, right? I'm on now, so I'm trying to figure out some logistical issues. So, okay. Okay. Okay, great. Thanks. Bye. Oh, did you figure it out?
No, I have no idea what I'm unmuted.
Should I just unmute all and then ask?
Yeah.
People? I wonder. Gosh. Why can't he? Did he mute himself?
I wonder if he did.
Should I just let these people in? Wait,
Yeah.
oh, where are all the people? Wait. I need Alan, Roberta. I'll just let them in, I guess. I don't know who Stanley is. Who's Stanley? Oh, Esther. Okay, I'm just the middle. Let's see.
Can you hear? And if you could
Explore new worlds and new ideas through programs like this. Made available for
Maybe I'll just do it this way.
contributions to the PBS station from viewers like you. Thank you.
Be more. PBS.
To celebrate turning 60, the amazing Andrea Bocelli comes home to great performance.
Okay. And starting my video.
Dr. Gardner. Just so you know, there's other people on the screen too. Like other people have joined, so.
Let's get started.
So everyone else will get started shortly. I am muting people who are not the presenters, and then we'll get started in a few minutes. And I will explain what's going on.
Okay, well, I have time to go get my coffee then, which is the
That is true. Oh, okay. Thank you.
Right there.
Oh,
Hi, Dr. Gottwein. Just so you know, there's a lot of people on the call right now, so good to see you.
nice to see you. I have to tell you.
Hi, everybody.
Hi, great.
Dr. Storch.
Hi.
Oh. Look how Leonard is here. Great.
One more minute for people, and then we'll get started.
Is the rabbi on?
Not yet. We'll give it one more minute for
Okay.
people in general to sign on.
So Ruth, we have one PowerPoint presentation with slides from several of the speakers. So when the time comes for the first talk, I'll just let me know and I'll open it up.
Okay.
I'll do share screen.
Okay.
What? You
Okay. Sending now. Sorry, I have one more minute. I assure you, just one more minute.
We're not on video.
What'd you say?
We're not on video.
I was having my cake.
So
Okay. We just need to get the rabbi on, and
I think he's on.
yes, he is on.
Hi. Sorry about that. Getting some trouble. The security is really good for this this Zoom meeting.
Good. Welcome.
Yes. So thank you everyone for joining us. It's great to see so many faces, and then at least virtually here, see names and faces of people. Yes, people are muted. Not, okay, well, sorry. Basically, I'm just going to go through the order of tonight. I'm going to be helping behind the scenes with things, and the Rabbi Silverstein is going to give some brief introductory words, and And then we have a wonderful panel of our physicians who Rabbi Silverstein will introduce, who are going to give a little presentation, and then we'll open it up to questions and answers. People are muted, hopefully no longer the presenters. The presenters should not be muted. People are muted. Please type your questions into the chat box, either to me directly or if you want to do it in the group chat. And during the question and answer session, I'll read the questions from people so that we have some order to this. So I'm going to let Rabbi Silverstein do some remarks.
Thank you. Thank you everyone for joining the call. I would say we're brought together tonight by two things that I don't think I need to tell you about the importance of, one of which is Jewish community and the beautiful community we have here at Beis Abe. And the other is the importance of protecting the life and health of our ourselves and our larger community. And I think everybody who's on this call is on this call because you understand that we are in an unprecedented situation, as we have been for some time with regard to the COVID-19 pandemic. And that these two are in a situation where in some ways we have two deeply cherished values of Jewish community and specifically communal prayer life and learning life, seemingly coming into conflict with the value of preserving life. As paramount in Judaism as is communal prayer, not only do we need a quorum of 10 men to be able to say certain prayers, but we're told that that God's presence literally rests among us, dwells among us whenever we gather together as a community for prayer or study. It's a very central, cherished value. At the same time, so is the preservation of life. And preservation of life is so central that for literally thousands of years, our tradition has taught that it takes precedence over almost any other mitzvah in the Torah. There's a famous Mishnah in Tractate Yoma, which talks about the laws of Yom Kippur, that says that on Yom Kippur, when it's a very important central mitzvah, central to Jewish identity and spiritual life, to fast. But if a doctor says a person needs to eat, we feed that person. And the Gemara goes on to explain that even if the person themselves says, no, I don't care what the doctors say, I want to fast. When the expert says a person needs to do something to preserve life, we violate even so weighty a transgression as eating on Yom Kippur to preserve life. And in the case of communal prayer, where although it's very important and a central value, we're not actually transgressing anything if we fail to gather for communal prayer. We all the more so should we listen to experts and their guidance about how and when and whether it is safe to engage in that activity. I'll add, I think it's worth adding that the Mishnah in question that talks about feeding someone on Yom Kippur on the advice of an expert was written down over 1800 years ago, when the highest levels of medical knowledge were orders of magnitude less comprehensive and less reliable than what we have today. And as flawed and imperfect as our understanding of the COVID-19 disease is, although that knowledge is growing every day, our experts are certainly more deeply knowledgeable about medicine, epidemiology, and public health than the medical experts at the time of the Mishnah. And even then, we were instructed, according to Jewish law, to listen to the advice of medical experts. And I think that's even, when the rabbis forbade a person from fasting against the advice of medical experts, that was a situation where the person's only endangering themselves. If I don't eat on Yom Kippur, I'm the only one who's going to suffer. Today, the reality is that anybody who takes a risk regarding exposure to COVID-19 is endangering not only themselves, but everyone they live with, everyone they come into contact with, and everyone those people could come into contact with. And so we're talking about potential danger not only to an individual life, but to the life and the health of an entire community and an entire society. And so and all the more so in this day and age and at this moment in history, it's a religious halachic obligation to listen to the advice of experts and follow their instructions as best we can about how to save and preserve life. Even when that comes up against other deeply cherished religious values. And we're blessed at Base Aid to have true experts in this area in our community. We have Dr. Maury Gardner, Dr. Tessa Gardner, Dr. Michael Gutwein, and Dr. Gregory Storch, who are very much experts in infectious disease and who've been extremely generous in giving of their own time and expertise to consult and advise Base Aid and the larger Jewish community about the best approach to take in this unprecedented time. And it's a tremendous opportunity as well as a religious duty to be able to listen to and heed their advice tonight. So with that, I'm going to turn it over to Dr. Michael Gutwein, who's going to update us on the general situation that we have with the COVID-19 pandemic.
And I'm sorry, just before Dr. Gutwein starts, I'm just going to repeat for the people that joined late that if you have questions that you'd like to ask, feel free to either send it to me directly in the chat or type it to the group chat and we'll ask later. If you asked questions when you signed up, the physicians have received those, so we'll make sure to address those as well. And finally, that this is being recorded if you need to pop out early or know someone who wanted to be here that can't. Okay, thank you. Dr. Gutwein, please.
Welcome, everyone. I'm going to talk about the general shape of the outbreak and what we know now or actually don't know now compared to what we thought we knew in mid-February when we last had a town hall meeting. Even what seemed to be a straightforward narrative of the novel virus jumping into the human race at the wet market in Wuhan is now unclear. It is clear it's related to a bat virus. It's not clear how it got into humans or if there was an intermediate host. What is clear about this virus is that it's extremely well adapted to humans in the sense that of adaptation so that it spreads very easily from one human to another, primarily by the respiratory route, primarily by respiratory droplets. There's controversy about whether aerosol, which is to say much smaller droplets that stay suspended in the air longer, also is a means of transmission. There's concern about surface transmission, but that seems to be much, much less of a risk. What also makes this virus well adapted to humans and causes it to spread so easily is that people who are asymptomatic or pre-symptomatic can spread the infection as well as people who are symptomatic, whether mildly or severely symptomatic. One characteristic of this outbreak, therefore, is the spread has been extremely rapid. It was first recognized in Wuhan in December. Within a matter of months, disease activity is widespread on 6 continents. Only Antarctica is spared. Well, the most recent data I could get from the Johns Hopkins website, which was on Friday, over 5.5 million cases worldwide, of which 1,700,000 were in the United States. Over 350,000 deaths worldwide, with over 100,000 deaths in the United States. And that death toll is probably an underestimate, not only because the statistics kept by the US and other countries are incomplete, to say the least, but because there have been many other excess deaths due to people not getting vaccinations, medical care, or choosing not to go to the emergency room with what otherwise would have brought them there. Another characteristic of the outbreak is that the distribution of the infection, that is to say the burden of disease, has been extremely uneven. There are geographic hotspots. all kidding aside, the blue states seem to be affected much more than the red states. Some of this is a matter of luck with early introductions into the population. Some of it is a matter of super spreader events, which will be addressed later. Some of it is related to population density. 4 out of the 5 densest counties in the United States are in the city of New York. And the outbreak there, which is the worst in the country, is amplified by the population density, by the reliance on mass transit, by the super spreader event at Kennedy Airport when flights back from Europe were about to be banned, but thousands of people were crowded together in Kennedy Airport. Other examples of crowding having an influence are the outbreaks on cruise ships, the aircraft carrier, nursing homes, and prisons, which also raises the issue of the burden is unequal, not only because of geography and population density, but poverty has a role as well. African Americans are disproportionately infected compared to non-African Americans. Actually, the highest affected group in the country is the Navajo Nation, which suffers from crowding, poverty, multiple disease comorbidities. Another factor that's affected the uneven distribution is the societal and governmental response to the introduction of infection into a given area. Compare the few cases in Taiwan and the possible complete eradication in New Zealand to the United States, probably the richest country in the world, having the worst outbreak in the world. There's been a fragmented and confused and inadequately prepared response to this infection in the United States, which also leads me to mention another epidemic that is coincident with the coronavirus epidemic, and that's an epidemic of misinformation, fed not only by trolls on the internet, but by mixed messaging, to put it in a kindly fashion, from the government, from saying the virus was a hoax to saying you should drink Clorox. That has an effect as well on control of the virus. That in a general way is where we are now. And I believe, Greg, are you next to speak?
Maury.
Yeah.
Maury, okay.
Good.
Maury will talk about transmission and how you can diminish your risk.
All right.
Let's see, Ruth, I have a message, host disabled attendee screen sharing. So I think you may need to do something.
Let's see. You have the PowerPoint there for everyone?
Yes, and Ruth, you're muted, but I can't bring it up until Ruth or somebody enables it. Okay, I think we're in business. Give me just a minute.
Okay. Good. Well, Michael has set things up well for me. My comments regarding how it's transmitted is directly relevant to what this initial part of the session is about, which is where are we at base A in terms of opening up. The city and county opened up, I guess, about 10 days ago. We are going to be talking about that. I'll have an opportunity to come back and talk about that in probably about 15 minutes. So why did it lead to a pandemic? And Michael's already given us the reasons for that. It's very infectious, and it's spread by coughing and sneezing and singing and shouting and talking and touching your face when you touch the surface that contains droplets. The question of aerosols becomes very important. It's something I've had a very special interest in particular for the past month. It's not controversial in China, but it has been controversial here, and the data had, up until very recently, just been based on finding nucleic acid, viral nucleic acid in aerosols and the like, but now there's information on which indicates that it's infectious because they can now grow the virus from these aerosols that are suspended. Loud talking, we now know, can send the virus up to 3 feet, infectious virus, coughing and sneezing, depending on how vigorously, up to 25 feet. There are countries in Europe right now that are asking for not 6 feet of distancing between people, but actually up to 20 feet of distancing for that reason. Or some even 30 feet,
10
but yeah, 10 meters, I think is what they've been talking about. Infectious virus has also been found in stool, and just very recently, within the past week, there was finally a paper that indicates that it is there in significant numbers. It's definitely infectious, not just nucleic acid. The virus in aerosols can survive for at least 3 hours. It's only been assessed. That's the maximum time that it's been assessed. Infection by asymptomatic carriers is critically important to why this became a pandemic. So now we have something that can spread readily, that can hang around in the air, can hang around on surfaces, and we have asymptomatic carriers who never become symptomatic, and pre-symptomatic carriers. If I could have the next slide, since I don't control that, I don't think. Great. I think you'll need to move that. Most of our information regarding aerosol spread only became available in the last 4 months or 5 months. It was last studied in a major way in the 1930s. This is actually a slide that was from a paper regarding strep in the 40s, actually, showing that they could, strep when people were sneezing, could be grown on a plate. It's a large particle, but as much as 9.5 feet away. Next slide. What we now, if I bring your attention, the upper left slide, here's the cursor. I'm not sure you can see that, you probably can't. But on the there, thanks Greg. The bottom part of the slide there is someone's nose. It's looking down from the top of their head. And those are aerosols coming out. And this individual is simply talking. And other views show it going to a person who's around, 3.5 feet, about a meter away that individual is speaking to. The slide on the right is very important. The 20 means 20 minutes. This was constructed from a model by some very talented people. And the individual, the second individual from the right-hand side, 20 minutes ago, the large droplets that used to be yellow in this model are now deposited and have been subtracted out on the floor. And the fine particles, the aerosols that are floating around now 20 minutes later are floating around.
Red.
And they're red, the red dots that are all around. The graphic below shows the size of the aerosol particles, aerosols when it's less than 10 microns. The larger ones deposit in the trachea. The very small ones, in fact, go down into the lung and right into the alveoli, which is where major damage has been done. And most of the deaths are due to a pneumonitis that develops and the immune response that's triggered by that pneumonitis. Next slide. So, how can we be safe from something that is just in the air, hangs around in the air, is invisible? And we've, after some false starts in hospitals initially with inadequate masking, as it turns out, and a lack of understanding that asymptomatics could be carrying the virus, so that people were coming in for other problems like heart attacks and strokes, were not checked and were in fact transmitting it to medical staff, and hospitals in other countries at least became foci of epidemic spread. That never happened here, but certainly it had an effect on healthcare workers. And what we learn in hospitals can be applied. So the germ theory is real. And once you understand how something is spread, or have a reasonably good notion, which we didn't have back in January 2020, February 23rd, when we first spoke about this, but do have a better sense of now. Social distancing, 6 to 8 feet. As I said, some countries are going to greater distances. Washing hands frequently, never touching your face, disinfecting high-touch surfaces frequently to eliminate the fomite, the large droplets that are accumulated on surfaces. Wearing masks or face coverings are critically important. Stay home if you're ill so you don't spread. Screen for symptoms and fever on entry into any building or place of business or hospital. Monitor for compliance and enforce compliance. It requires a major culture change. I could have the next slide. The simple 2-layer cotton or surgical mask reduces droplets, the big droplets, by 99%. Overall, it's said right now to be about 60% effective. And if 60% of people wore these masks that were at least this effective, then the epidemic spread would come to an end and we would just have endemic low-level spread, which is what we're aiming for in the absence of a vaccine. Next slide. And so one of the critical interventions until a vaccine is available does appear to be masking for the large droplets, for the smaller droplets, and for the aerosols who appear to be playing a role. Next slide. And that is what I wanted to say about the aspects of spread that are relevant to what we're going to be talking about a little bit later. Greg, I think you're next.
No, I'm next.
Yes.
Oh, that's it next.
Yeah,
Okay.
can you, okay. All right, so I'm going to do this as quickly as possible because I can tell you what you need to know about children fairly quickly. Okay, so first of all, the first slide shows, this is from the American Academy of Pediatrics as of 10 days ago. And this shows how many cases we had. 1.3 million cases in the United States. We had 50,000 cases in children. So that, it's not that many in children, but it's still a lot. And so that means that the risk, that the chances of any one child, it's like a ratio of one child that's infected out of 1,000 or more people that get infected. So we're not talking about a large number, but it does happen. It adds up to a large number when you get to 54,000 children. Some states have a higher incidence of testing, and they may have a higher incidence of finding cases. But anyway, it turns out that about 4 to 12% of cases happen to be children. In the American Academy of Pediatrics, all the reports, we consider children up through age 21. So that's most of the time. So almost always 0 to 19, sometimes 0 to under 21. But okay, so now if you see the hospitalizations, 0.5% to 2%, children comprise 0.5% to 2% of total hospitalizations. Children comprise less than, around 0.5% of all the deaths. So that's good. Could I have the next slide, please? Okay, now if you go down here and look at the bottom, I don't know if, Greg, you can put the cursor on the last one, Missouri. Okay, so this is from the same thing, May 21st, across the nation from the American Academy of Pediatrics. You can see that Missouri has, how many children are in Missouri? 1.3 million children exist and are alive in Missouri. How many child cases? Less than 400, so 384. Okay, so the percent of children of the total cases is 3.5%. Okay, of the total 11,000 cases that we've had reported in the state. Next slide. Okay, this is the mortality data. Same place, American Academy. Missouri is at the top. So again, Greg, I believe there were a couple of two children that recently you're aware of that passed away. But as of when this was 5/21 and what was reported, there were no deaths in children. So of the total deaths in the state, it was around 600 with no deaths in children. That may be changing, over the next some time. Next slide, please. Okay, now the reason that we're concerned, you see children, first of all, children generally get milder symptoms. Anyone may have no symptoms, and some people may have mild symptoms regardless of their age, but in general, children tend to have milder symptoms. However, there is a newly recognized severe disease that fortunately is quite rare still, And it occurs around a month after a child gets exposed or comes down with COVID-19. So it's not something that they're getting at the time that they're getting sick with it, or the time that they're getting it, even if they have no symptoms. They're getting it around an average of a month later. So at this point, we think it's more like an immune response of the child's body, which attacks the blood vessels and causes a disseminated, generalized intravascular inflammatory process that affects all the systems that the blood flow goes to, which is basically every part of the body. So if you, and I will have some slides at the end to show you what the rash and what the symptoms look like, but I just want to go over this quickly. This slide is called MISC, M-I-S-C, Multi-Inflammatory Syndrome of Children. When we talked to you in February, we didn't know about this, but all of us as pediatric infectious disease people have seen what's called Kawasaki disease for many decades. We're familiar with it, we know how to treat it, and we know its complications, we know its presentations. This MISC disease is very similar to Kawasaki's. The difference being that true Kawasaki's used to hit toddlers and younger children. And this disease averages, the average age at which children come down with it is 8 to 10 years old, and it occurs in people up to age 21. So it's basically the common symptoms by the time a month after their exposure that they come down with this MISC. They have a fever, a rash, abdominal pain, diarrhea, vomiting. Some of them have red eyes. I'll go through these in a little while. They may be confused or sleepy. We know how to treat Kawasaki's disease, and these children have been largely treated as we treat Kawasaki's patients, which is we give them high dose intravenous gamma globulin. They require hospitalization. Any child with these symptoms you should seek a medical attention by calling your care provider immediately, and that the care provider will most likely send the child to the hospital where they can take appropriate precautions. What we are finding is that these children are not often still positive for the virus when they come down with these symptoms. So they still have to take precautions, and you don't want to just show up at the hospital without notifying the hospital, but it's probably a less risky situation for the caretakers. So it's usually, as I said, about 4 weeks after the COVID infection or exposure, and it occurs between 6 months and 21 years, peaking at 8 or 10 years. And let's have the next slide, please. Greg?
Yeah, just a minute.
Okay. Okay, so this is how the case definition. The World Health Organization has a slightly different case definition. The CDC is the one that we're pretty much using in this country. And the symptoms that you look for are, I put them at the top, and then I'll have some slides showing what that looks like after this. So the symptoms are high fever, not that high, but it could be, but 38 degrees centigrade or 100.4 Fahrenheit for at least 24 hours. And a red, blotchy, really weird rash that you've never seen before. It's not like anything you've ever seen before. And red lips, bright red lips, bright red tongue, bright red eye, the conjunctivae, the inner eyelids and everything. Red palms and soles, looking almost like the hands have been dipped in paint, the palms or soles. The hands or soles may get swollen. The child could be very, very irritable, really crabby, could be listless and lethargic. There could be gastrointestinal symptoms like diarrhea, vomiting, and abdominal pain. As this progresses, the blood pressure drops, the child becomes very sick. So that's why when you see these earlier symptoms, you do want to call your healthcare provider and get the child evaluated. Now, here's the definition, just for those who are interested. You have to have a certain degree of fever. You have to have evidence of having inflammation. They can do that with a blood test. And it requires more than one organ to be involved. And the organs it hits are the heart, the kidneys, the lungs, the brain, the blood vessels, the skin, and the brain. And the intestine. So there can't be some other diagnosis. It has to be no other diagnosis. So, and there has to be a history of being exposed to or having had COVID about 4 weeks ago. Next slide. Greg?
Yeah.
Okay, this shows, and this is from a hot off the press paper that I think is even a pre-publication, and with permission from the, they give a citation. So this is the red lips. I have actually seen with Kawasaki's much redder lips. They tend to be cracked and red, You can't really see the eyes on this slide, but on the next one, here's more of the red lips. Here's the hand, the palms. And you turn the hand over and it's pale. And sometimes they have little blotches on the back. Here's a blotchy rash. Here's a funny looking kind of rash. Here's swelling in the feet. Next slide. Next one. Okay, now this one is much more impressive. This is in a younger child, and this is how Kawasaki's has looked to us for decades. But and this is a younger child. So here you can see a little bit more of the redness around the inner eyelids. And here you see this very weird blotchy rash. It's bumpy, it's raised, it's flat, it's red, it's pink. It's called polymorphous, which means it has many changing shapes. And it's not hives. And so if you see something like this, that is something that you need to call your doctor about. Okay. I think that's the last slide, Greg.
Greg, you're up.
Okay, thanks, Tessa. Good evening, everybody. I'm going to cover a few areas. So those are testing and treatments and vaccines. And then Maury will come back and talk some more about possibilities and strategies for school opening. And then, of course, we'll have time for questions. So the testing comes in two main varieties, viral tests and antibody tests. The viral test was available the last time we spoke, and that is a test that's done on a nasal sample, and it's a nucleic acid amplification test. It detects the RNA of the virus. And the important thing to recognize about it is it's a measure of whether the person is infected at the time that the test is done. When a person becomes infected, there's an incubation period of typically about 6 days or so. And somewhere towards the end of that incubation period, the person would start to have a positive test. And the positive test would last for about 2 to 3 weeks, probably sometime after the end of the period of contagion, but then the positive test would disappear. So that's what the PCR test, the nasal test does. It's very important to keep in mind that it's not a perfect test and it doesn't detect everybody who's infected. The sensitivity is said to be about 70%. In other words, if you test 100 people who really have COVID, about 70 of them will have a positive nasal test. Sometimes if you repeat the test a day or two later, it'll turn positive, or sometimes in the hospital, we do it on a different sample, like a sputum sample or a lung lavage sample in it, and then it can be positive. So it's a good test, but it's an imperfect test. And earlier on, there were major problems with availability of the test. That has gotten much, much better, but it's still not quite as available as we like. And part of what we're dealing with are global shortages of the test components, because everybody in the world is trying to do this test. In many countries, trying to do it on large population groups. And so understandably, there are some issues with regard to availability of the components that are required for the test. Now, more recently, we've had the introduction of antibody tests. Antibodies are substances that are produced in response to an infection. They're present in a person's blood, and it takes a little while for the antibodies to become detectable. And in the case of COVID, they become detectable probably about 7 days after the beginning of symptoms. So the antibody tests are not primarily used as diagnostic tests, but the antibodies will remain in a person's blood for some extended period of time after they first appear. And in the case of some infections, this can even be for the lifespan of the individual. So when you get a positive antibody test, it tells you that you have been infected with that particular virus, in this case SARS-CoV-2, sometime in the past. It doesn't tell you exactly when. And we don't know the duration of the antibody positivity in this infection. But it's very good for doing surveys of the population. If you want to find out, let's say, if we wanted to know how many people at Base Abe had experienced COVID, knowing that some might not know about it because it was asymptomatic, we could take a blood test sample on everybody, test it with an antibody test, and come up with an answer. And where that's being done in populations in the United States, Generally, the result has been between about 1% and 5% of the population has been positive. The highest I've seen is in New York, where about 15% are positive. Now, a very key question about the antibody tests is whether a positive antibody test corresponds to being immune to the infection. In most viral infections, that is true. And we anticipate that that is probably true in this case as well. And that will be a very, very important development when we have proof of that. But it's not proven at this point. And so people should not assume that because they have antibodies, they're immune to subsequent infection. There are examples of viral infections where people develop antibodies and yet nevertheless can get an infection again. And influenza is a very simple example of that. But we will see, and if it turns out that antibodies correspond to protection, that will be very important because that will allow us to identify certain individuals in the population who could take more risk, who might be people who could really be on the front lines. And conversely, it can identify people who are susceptible, who may need extra protection. The slide lists one other thing with it, which is antigen tests, but that's something more for the future. Okay, treatments are limited. There is an antiviral drug called remdesivir, which has shown to be effective in that it seems to shorten the illness by about 4 days. It's an intravenous antiviral treatment, and it's still of limited availability, hasn't been fully approved by the FDA, but they are making it available to people. But the supplies are such that not everybody who might benefit from remdesivir can get it right now. It is probably, in the end, we'll probably come to the conclusion that this is a good drug, maybe not a great drug, probably not in and of itself a game changer, partly because it has to be given intravenously for a 5 to 10 day course of treatment. You've heard a lot about chloroquine and hydroxychloroquine. We talked a little bit about those last time, and more evidence has accumulated since then that these drugs are probably not effective. We really don't have the definitive answer yet, but I think most people don't think they're going to be extremely effective. They may have a weak effect, or they may have no effect at all. And we are increasingly aware that they can have side effects, mainly on the heart, that these can promote certain heart arrhythmias, not very often, but occasionally. And so people should not just take these drugs willy-nilly. You may have heard about a drug called tocilizumab and another family of drugs, steroids would fall in this category, that are not antivirals, but they modify the immune system. It's thought that the overactive immune system at some points in the disease may play a role, and that if you could get in there and down modulate the immune system in certain ways, that might be helpful. This is still being evaluated. And then you've probably heard a lot about convalescent plasma. This is the concept of harvesting blood from people who have had the infection and separating out the plasma, which is the part of the blood that contains antibodies, and then infusing that plasma into a person who's sick, or possibly a person who's been exposed, with the hope that the antibodies would help treat the infection. There are a number of infections where antibody treatment can be helpful, and so there's hope that this might turn out to be effective, but we really have no proof at all right now. Convalescent plasma has been given at least tentative go-ahead by the FDA for what's called emergency use, and so people can get treated with plasma. There are some problems with availability, but it's fair to say that all of these measures are of some help, but they don't necessarily turn every case around. And let me close with a little bit of information about the vaccine. We did talk about this a little bit last time. The update is that things have continued to progress in positive directions. About a dozen vaccine candidates are being tested in humans, and we did have a jump start on this because there had been a body of research trying to develop vaccines for the related viruses, SARS and MERS, and some of those vaccine candidates were reformulated to be directed against SARS-CoV-2, and preliminary data, very preliminary data, from 2 or 3 of the vaccine candidates is positive. So they are moving forward now to phase 2 or even a phase 2/3 trial. These are trials where larger numbers of patients are tested, and we have to see if the vaccines really are effective in producing immunity and in protecting people, and we have to make sure they're safe. And of course, we can't neglect the aspect of manufacturing of a vaccine to the point where it's available for populations. That's a very large task, figuring out how to distribute it. So we know that absolute very best case scenario could be availability of a vaccine this winter. That would really be a best case scenario, and it's entirely possible that it could take several more years or even longer than that for a vaccine to become available. But you know, if you've listened to Tony Fauci, who's extremely expert in this area, he is guardedly optimistic that we will have a vaccine in less than 1 year from now. So let's hope. And some of the companies with assistance from governments are actually already beginning to get production facilities in place with the idea that they'll have a jump start in producing large amounts of the vaccine. So with that, I'm going to turn the podium back over to Maury.
Thank you. And if we, yeah, so our major incentive for having this session was to talk about the shul. As we just heard, we can't expect to have a safe external environment outside of our homes for about a year. So we need to use the information that we have to begin opening those parts of our existence, our lives that are important to us. And we have been working carefully to figure out how to bring more than Zoom sessions into our lives from Base Abraham. Next slide. So the closeness of our community is really very characteristic of other Orthodox communities. And Orthodox observance brings people together frequently, and people live near one another. And as Michael already told us, and as I tried to reinforce, major spread is a result of clusters of infection and clusters of infectivity. And most of those are inside. They're either in homes or in businesses or in crowded, congregating social settings. And shuls, qualify for that. There's one very telling and very important case that's been reported within the past month. It was a choir practice in a church. Involved 62 people. There was one individual who was pre-symptomatic. She became ill 2 days later, but was asymptomatic at the time that participated. This was reported because the case tracing was excellent, and they ran every single person down. And it turned out that over 50 people became ill. Over 30 were ill enough to go and at the time fulfill criteria for testing and tested positive. And 2 people of the 62 died. They spent 2 hours singing. And what the recent evidence demonstrates is that singing produces a lot of aerosols, many more aerosol particles than just talking or talking loudly. And they were in an enclosed space for 2 hours. That's very similar to, what we do, whether it's at weddings, sometimes it's shul, depends, when it's at simcha. But it turns out that the quality of the air inside is very important. And that's something that we really have to learn a little bit more about. The CDC has taken some baby steps in saying that it's worth looking at your ventilation. And it turns out that people who know the most and have been studying aerosols for a long time of all sorts, particularly in the industrial area, indicate that the only way to really get rid of aerosols is to replace the air. Basically, you need, you open 2 windows, one on one side of a building, one on the other, the air flows through. But we owe it to ourselves, because nefesh, as our rabbi has already told us, is of primary importance to us as we make decisions about the shul. And while we need the spiritual support of the shoal, we don't want to place lives at risk. So next slide. Our initial recommendation was to wait at least 3 weeks after the county and the city open, because that's how long it takes for hospitalizations to start going up if in fact you have spreading events. If things start going in the wrong direction, and I must say that from what I've seen on the street and from what we've seen on TV, one worries a little bit that people are not taking the precautions outside of their homes that they should ideally be taking. The city and the county made an appropriate decision to begin opening up, and the guidelines that they've published are in fact very reasonable. It's just that people aren't adhering to them. They could have perhaps taken a stronger stand, but if you can find those on the web. This shows a curve. The upper one, the blue line, you can see that things went down, clearly went down from the peak in terms of hospitalized cases for about 14 days before the city and county decided to open up. I'm not sure whether that had much of an effect on how the state made its decision, but it was an evidence-based decision on the part of the city and county. And down below, indications of ICU COVID patients and ventilator COVID patients, and everything trended down, flattening of the curve due to extreme social distancing with us locked down in our homes. Next slide. This shows, this was pulled, I pulled it today. They're now reporting weekly from our local St. Louis task force. And this shows the curve from March 1st, weekly, it's a average, a moving average until this past Monday. There'll be a new report tomorrow. You can see, Greg, you can sort of follow that along with your cursor. You can see the peak, you can see how it trended down. It became a little steeper, went down, and now it's been really pretty flat. It hasn't continued to go down. That's what we're keeping an eye on to see how, in fact, we should, how aggressive we should be in terms of opening.
Do you want to explain what the 7-day moving average means?
Yeah, it's just an average of 7 days, the number of hospitalized patients. We can't really in Missouri, and not in most places here in the United States right now, except maybe New York, we can't look at new diagnosed cases because the testing has been steadily increasing. So that may just be a reflection of increased testing. In countries where they've been testing aggressively, testing, tens of thousands of people a day in areas, they can look, and that's what you'd like to know, are the number of positives going up, because that precedes people becoming ill and ending up in the hospital, that small percentage that becomes ill and ends up in the hospital. But it ends up being a lot of lives just because there's so many people infected. We talked about 1.5 million, and that's demonstrated in infections, by testing. I think everyone believes that it's at least 10 times that number nationally, and perhaps even much greater. Next slide. So things is really right now are flat, not going up yet, but flat, and it'll be more telling in a week. So a phased approach, St. Louis individual and general business requirements are listed there, and it's actually very reasonable. They lifted shelter in place, except for the most vulnerable, those over 65 and those who are immunocompromised or have significant organ disease. The schools have remained closed, limited business openings, offices, restaurants, hair salons, hotels, churches, and there's specific guidance for most of those. The general business requirements, which are listed here, apply to shoals. Groups restricted to 10 or fewer still, so we can make a minion, but not more. Maintain social distancing, 6 feet, using barriers, markings in places of business, hand and facial hygiene, provide hand hygiene and disinfection supplies to employees, frequent cleaning. Businesses need to provide temperature and symptom checks that people showing up. Employees need to be free of symptoms and need to be not have a fever. Provide and use masks when indoors. That's a requirement in St. Louis City and County and places, all the places listed there, which would also apply to shoals in St. Louis City and County. Maintain travel restrictions, still only travel when it's essential. monitor infection rate via hospitalizations, as mentioned, and then expand testing and contact tracing, which we're still not doing very much of. Greg, next. So they will go on to phase 2 only after infections actually go down for 14 days. And they just announced, I think on Friday, that they are not, that the earliest they would go to phase 2 is June 15th. They're waiting actually an appropriate period of time since they're monitoring hospitalizations, and those lag by 3 weeks. If the infections go up, they will figure out how to go back in terms of opening. Next. And then what Base Abe phase 1 for us, we have made a decision that we'll be taking to the board, baby steps. The target date for initial opening of anything is June 8th. We'll continue all the Zoom sessions. The Scholl building will remain closed because of the concerns about shedders, super shedders, asymptomatics, and the cluster infection phenomena that seems to characterize the spread of this virus. Outdoor morning minyanim is what we're working on beginning. Next slide. What that will require, limited to 10 men, ages 13 to 64, who sign up and commit to the following: to adhere to prescribed 8-foot social distancing while on Scholl property in our side yard, no congregating on entry and exit, 100% mask use while on property, certify the absence of any defined symptoms before entering, basically go through a checklist and indicate that you don't have any of those symptoms, submit to an infrared temperature check. Hand sanitizer will be available and should be used on arriving. No children, high-risk men discouraged from participating, which will be a problem in terms of our getting a sufficient number potentially. And the rules need to be enforced by someone who's attending. Use the bathroom at home before arriving, because using the bathroom requires going to the building. We will have supplies to clean the bathroom and allow individuals to go in one at a time if it's absolutely necessary. It's an emergency, but we're asking people not to enter the building.
And they have to clean
and we'll leave supplies so you can clean up after yourself and clean for the person who's going to be coming in next, and have the option of cleaning when you go in initially. Physical layout: 2 chairs spaced 8 feet apart, one for the participant, the other for whatever else you need with you, your talis, your tefillin. A solitary Balkora will do all the reading. We'll do Hagba and Galila, Sephardic style. And Aliyahs will be at one seat, or perhaps taking a step forward.
The 2 chairs would be together for one person.
Those 2 chairs are together for
but
the same.
But then they would be separate from the other 2 chairs.
That's correct. Next, just the basic truths that we have to deal with in this viral pandemic is that viral behavior is predictable as we learn more about it. But whatever we learn, it does appear to be predictable, as we've seen with other viruses in the past. Viral behavior cannot be changed, regardless of how much we would want for it to change. It's as infectious now as it was when it started in Wuhan. Human behavior, on the other hand, is unpredictable, but it can be changed. And it needs to change to accommodate the viral behavior. Next slide. And this is a photograph. We don't have our own. This is a photograph of a West County Scholl that's initiated or is initiating their minyanim. The chairs are spaced, you can't tell from this, 8 feet apart. They're supposed to have a little table next to it. Greg, I believe you were out there actually, and saw that. And what we see above is a canopy. It's open on all sides, but it has a canopy just to protect from the sun because it's in a parking lot. Right. Next slide. And I think we're going to be open for questions now.
Mm-hmm. Ruth?
Sorry.
Do you want to put us back on? Let's see our pictures. Can you put the photographs back on? Do you want us to just start with the ones that we already have, Ruth?
Oh, okay. Let's see. How do I do that?
I'll tell you what, I have the questions right here. Do you have a copy? If not, I can go through them.
Let's read the questions.
The rabbi is asking to be
The
unmuted.
rabbi desperately wants to talk.
I'll go ahead and start.
Ruth, do you know how to unmute the rabbi?
Michael, I think you're unmuted. Greg, you're unmuted. We're unmuted.
Ruth is muted. Ruth should probably not be muted.
Okay. Yes. But I'll go ahead and ask the question.
Oh, wait. Can you unmute Ruth?
No, that's up to her.
Hover over name. Let me see that again for a minute. Oh, okay. Okay.
Why don't you unmute Ruth?
Yes, I'm trying.
Oh, she shifted.
Okay, sorry about that, everyone. Had some technological, this is the inner workings, the behind the scenes technology of it all. Dr. Storch, I think, just real quick, sorry, if you hover over my name again, there should be an option to make me the host again, and then I can help with all of that. There should be 3 dots.
I see it, yep.
Yeah.
Okay.
Okay, thank you. Okay. So there were questions that I gave you from before, if there are some of those that you want to address, or if you would like me to read them to you, or some of them.
I'll go ahead and do the first one because I think it's important.
Okay. We also have some questions that came in through chat, so after you're done with these, I'll ask a few more.
We should alternate on that. Why can't we just require that everyone entering our schools masks, have a temperature and symptom check, wash their hands, socially distance, and then with these safety measures in place, start davening as before? And the main reason is that we're concerned about the quality of the interior air. Is it being vented? A large number of individuals using standard masks are they're going to be aerosols escaping, and they're going to accumulate over the course of an hour and a half or 2 hours. And the masks, the simple mask, my mask protects you and your mask protects me, but they're actually not very effective in preventing inhalation of aerosols that are generated. So if you have high levels of aerosolized virus, the simple mask will not, hovering in the air in front of you and all around you, then it doesn't protect you. So it's too early. We have concerns that this approach, if we all wore N95 masks, prevent the aerosols, if they're properly fit, then perhaps we could go on, but not before.
Yeah, if I could add something to that also, I think we do think that the level of virus in the St. Louis area is going down. But on the other hand, we're also concerned about possible resurgences. And we have situations just over the last week or so of the situation at Lake of the Ozarks and the demonstrations that are going on. These provide great opportunities for transmission, reamplification, and potentially a resurgence. So I think it's very important for us to go a little bit slowly right now and gauge what the impact is of those events.
Ruth, do you want to catch one of the questions?
Before we go on with the questions, I just want to comment on something that was mentioned in the description of reopening procedures, which I couldn't comment on in real time because I was muted. But I believe one of the things we discussed when we were meeting, Ruth and I and Larry and the 4 doctors were meeting, is that we don't want to create a situation at any point where we're saying, even in these intermediate stages where we're saying services are going to be limited only to those who count towards a minion, which it looked like was being implied from that slide, and I'm pretty sure we it's something that I think is very important. I think in terms of Base Abe's values, that we don't have a situation where we're saying women can't come to shul, or if you don't count towards the minyan, we don't want you there for any reason, because it's just not who we are or what we're about. But obviously we have to balance that against the need to keep the size, even in our open backyard with spaced out. There's a limit to how many people can be safely accommodated, and we're going to work we'll work on disseminating the proper procedures for how to do that in a way that is both in line with our values as a community and mindful of public safety and what's reasonable and safe.
Ruth, would you
Right.
like me to take the second question?
Sure.
Okay, I have been asked this question by numerous people from all over the country, and I think we really can't answer it.
Can you tell the I'm sorry, Dr. Gardner, I don't mean to interrupt. Can you repeat the question for the
question
group,
is,
please?
what is the earliest we can plan a typical Jewish wedding with dancing for 150 plus people? I've gotten this question in some form or fashion several times over the past few weeks as different parts of the country open up in different degrees. I think that at present it's very difficult to think about safely having a group that large dancing, because you're breathing heavily in close contact. Even if you try to dance 8 feet apart, and outdoors, it's very difficult. And I think the large number of people places more people at risk if one person is an asymptomatic shedder. And so I don't know that we have an answer to that right now. I think it's something that we need to follow, and what many people are doing who would like to have that large wedding, they're having a smaller one, and they're having just the essential people. And then they're planning something for a year from now, which would be a bigger celebration. So I think it might change, but short of a vaccine or a wonderful drug that you could take if you got exposed or preventatively, I just don't see 150 people getting together in this setting in the near future.
Thank you. We have a few questions, both on your list and from the chat, that I'm kind of grouping certain questions together. So, please let me know from everyone else if your question is not answered appropriately. We have a couple questions about either relatives or people in nursing homes and senior living communities. One question about keeping relatives safe who live in those situations. Just any tips or any guidelines that you might have. And also, does COVID-19 present differently in elderly adults, and any information you can provide on that age demographic?
Okay, I can take a crack at that. It does present somewhat differently in the elderly, as with many other infections. The signs can be more subtle. Sometimes it may just be fever, or it may just be a deterioration in conditions. So the diagnosis can be more subtle. The other thing is that as there have been investigations in nursing homes, it's typically found that a significant percentage of the people who are positive actually have no symptoms at all. So it can present without any symptoms. It's the first part of the question is really hard because I think in terms of precautions that you can take, there's not much that you can do because the person is in the facility, and it's really up to the facility to be undertaking precautions. One thing that's been seen in some recent publications is that there has been good success in controlling COVID in nursing homes, when the key is to do quite a bit of testing and separate the people who are infected from the people who are not infected, both workers and people in the nursing home, and then come back a week later or so and do another round of testing, and that has been successful. So this is a very, very difficult problem in general. It's a big part of this outbreak, and we're still in a learning process, unfortunately.
Brett, the only additional comment I would make is to check with the nursing home and see what their COVID plan is. Every nursing home at this point has to have one. They should be cohorting, separating infected from uninfected. They should be testing. Everyone should be wearing masks. Visitors should still be limited, but they should be testing their staff. It would appear that staff, were the introducers in most of the settings that have been worked up fully. And to Missouri's credit, they're not going to go to phase 2 until they complete their nursing home mitigation efforts, which apparently they're working on. Thank goodness our governor seems to feel that that's important. He's using what's going on in St. Louis County as a model for the state regarding nursing homes. So there are things that one can do in that regard and find out if they're mitigating. This is going to go on for a while. So if a nursing home isn't doing what it should be doing, everyone's not masking, including the people who are able to, who are residents there, then one would think about trying to get them into another nursing home over not the short term, but over the longer term.
We also have a series of questions just about returning to daily life in general. We have one question: when is it safe to go back to places like a beauty shop or barber to get haircuts?
Michael, do you want to
You
try
want to take that?
I mean, Maury also covered it in terms of the St. Louis County plan there. The grooming establishments will be open.
Yeah.
I think they still have some risk, even though the government has allowed them to open up. And I think a person in a high risk category, someone who's over 60 or 65 or who has other disease that increases the risk of infection, should stay out of those places. I'm not going to, as you can see, I'm not getting my hair cut. And it's going to be a while.
You can buy very good hair cutting shears.
That's how I got white hair in the first place, Tessa, but that's a whole other story.
Yeah, I
No, but
looked
for other people.
I looked over the guidance for beauty shops and barbers, and they're required to mask, although there isn't a requirement that their customers mask, an absolute requirement, and that's a problem because they're at significant risk of becoming ill with the other individual not masking unless they're wearing, very high efficiency masks like N95s. They have to use hand hygiene in between customers. And they shouldn't have people congregating in their shop. But other than that, that's it. So again, it's an inside environment, may have static air, no way to know what the airflow is like unless they have windows and doors that are open. And I would view that as high risk.
You make an interesting point, because I have heard of some people making arrangements to have outdoor haircuts. And I think that would be safer, because we think the risk of transmission in general is much less outdoors than indoors.
Yeah, I think someone right now could do well being a traveling barber on people's backyards and patios.
Yeah, but of course we have to keep in mind the barbers, the hairstylists are at high risk themselves because they're coming in contact with a number of different individuals.
Exactly.
Wouldn't the mask wearing that's required indoors cover that? I don't understand why, if St. Louis County is still saying you're supposed to wear a mask indoors.
Employees only. Yeah.
Well, we need to lobby our local governments to
right.
do that.
Customers should be masking.
Makes sense.
I've been working on the city for some time and can't get anywhere.
And I'd just like to call to people's attention, there was an article in the news a week or two ago about 2 hairstylists in Springfield, Missouri, who worked while ill with COVID and exposed something over 80 customers to the virus.
It's not just legislators who do that. People who cut hair do that also.
We have a couple questions in a similar vein as well about when is it safe. I'm combining questions again. When is it safe to start having small social interactions with people outside your immediate family, whether it's a meal or some kind of social gathering, both from a a physician standpoint, and also Rabbi, if you wish to comment on at all on some of these kind of thoughts about gathering.
About this.
I could address that as a bubbling phenomena. And many states and countries, Canada, for instance, and Alaska, for instance, have a concept of bubbling with another family. So if you can identify a family that has identical precautions and protective behaviors and exposures to your family, and you can trust them, and they can trust you, and you both families feel that they are safe and not contagious, then you could try bubbling with one family. And that may help a lot with children playing together, or, that means bubbling without masks and without social distancing, but you'd have to have complete trust in the other part of the bubble. It's almost like taking a pledge. I pledge that I will observe these same behaviors and you will too, because I don't want to infect your family and your family doesn't want to infect my family.
Right. Important to say that the bubble is only as safe as the least safe individual within the bubble. But I think it's a very good concept.
And does anybody want to comment on how big a bubble safely could be? I mean, most of us are thinking of 2 family bubbles, or at most in exceptional circumstances 3. The more family units that you include in a bubble and the more individuals that you include in a bubble, the higher the likelihood that somebody's going to be infected, whether they...
Human behavior is so unpredictable.
The other thing is that you can't get mad at your bubble and go bubble with somebody else then. That people need to think carefully who they're bubbling with, because the idea of constancy is important. That if you're bubbling with another family, you want to keep it to that family.
Rabbi, do you have anything that you wish to add to that?
He's mute.
I think this is an area where it's really important to defer to the experts. I do wonder, I'm wondering for the experts, as the more I hear more and more about people who are cutting corners, as it were, on the kinds of precautions they were taking 2 weeks ago or 3 weeks ago or a month ago. To what extent, in halacha, we have a concept of lechatchila and b'diavad. There's the ideal thing that we all agree you ought to be doing. And then post facto, if you're not able to or willing to do that, what's the next best thing? And I don't know if you have any, for those who are simply, they're crawling out of their skin, and not saying that they should be violating these guidelines, but are there safer and less safe corners to be cutting? And how do you deal with that when you know people are, if you set the guidelines at a certain level, that a certain number of people are just going to ignore them?
I think one thing that's very important to keep in mind in relation to that is that people have very different risk profiles themselves in terms of their likelihood of getting infected and how sick they will be. So a healthy young person without underlying diseases is probably going to have a mild illness and recover. Now, there are exceptions, but the percentages are in their favor. On the other hand, if the person is in their mid-70s and has other medical conditions, they're very vulnerable to getting very severe disease, even fatal disease. So corner cutting is much better tolerated by young, healthy people than by people with risk factors. And we have to keep in mind, who are your household contacts? Who are the people you're going to expose? You may be a healthy young person, but if a grandparent is living in the household with you and has those risk factors, then you also should be very, very strict.
The bubble includes everyone in your household and all your contacts, all your close contacts.
Okay. In a similar, I guess, close to maybe the hair cutting question, we have a question about going to the grocery store if you're over 65. Is that something that are people able to start grocery shopping for themselves a little more, or any guidelines you have for those kinds of?
The concern right now needs to be that the risk during this initial phase, until we know that it's actually working and risk is, and cases are going down, is actually greater now than it was when people were sheltering at home. So grocery stores are probably less safe now than they were before the county reopened. It is finally mandated that employees have to be provided of some sort, simple masks, but there is still no requirement that the people entering the grocery stores in St. Louis, many other cities it is required around the country, but in Cleveland, but here in St. Louis, it's not required. So if you go into a grocery store and there are too many people in there for the air turnover rate, the exhausting rate, then aerosols accumulate and droplets, accumulate, and the risk is there. That's my view. Greg, Michael?
I agree. I think there's still some risk in grocery stores until we know really more definitively that the incidence of the disease is really going down. I think people with risk factors should try to avoid them.
And we do have a good community at Base Ape where people can shop for others that are older. And also we have a lot of local delivery and drive-by window pickup services. So I think it's certainly possible for most people to get the groceries and medications that they need in other ways.
Okay, one more, I guess, at least for now, social distancing question, and then we'll move on to the next set of questions. Is it okay, we have a question, is it okay to have a small group visit with you outdoors? So 1 or 2 individuals outside, like on a deck or in a yard, that if you're taking the precautions that have been mentioned, like wearing a mask or not, maybe, sitting at least 6 feet away and so on. Can you give any guidelines on outdoor socializing, I think is the gist of the question.
I think we do think that outdoor socializing done carefully can be okay, as long as people are more than 6 feet apart. If there's any question of being less than 6 feet apart, they definitely should wear masks, and they might consider wearing masks anyway, just to be extra safe. And I think they should limit the number of people that are involved. But I think if it's done carefully, I think it probably can be done outdoors.
There's another factor there, that if there's food involved, what is recommended is that if you're having someone over from a different household and you're having any kind of food at all, you be very careful that you haven't contaminated the food, and that you have separate tables and separate containers, have duplicate containers, one for your family, another one for the other family, so that there's not dipping into each other's containers.
And the other risk comes from the person who shows up for the picnic who shouldn't have shown up for the picnic.
Walks into the backyard and says,
an asymptomatic sheddar, or the person who walks by you 1 foot away because that's the quickest way for them to get to the part of the park they're going to.
That's why masks
in behavior.
But this goes to the bubbling phenomenon too, so that if you're bubbling with another household and you're in agreement about what your precautions are, you can get together in your backyard. I might still consider, if there are children involved, having separate serving things for each bubble, each sub bubble, just to reduce the risk, but you can do that.
And especially, it sounds like without food is probably better. I'm sorry, I'm going through some of the questions in here. Dramatic pause. We have a question. How long do antibodies show when getting tested?
Well, I think maybe the person is asking how long are they present for, and we don't know. If we look at other viral infections, the shortest would be several months, the longest would be the lifetime of the individual. So I think we just have to wait and follow out people longer until we learn the answer to that question.
Greg, I guess based on other coronaviruses, it's probably not going to be for years.
It's probably going to be months rather than years for most coronaviruses.
Do you have enough information to?
Yeah, I think probably in the case of SARS, most people were still positive after about a year.
But we don't know, beyond that. In terms of the 4 coronavirus common cold coronaviruses that circulate in the United States, it's my impression that at least in terms of immunity, it's only good for about 4 months, 4 to 6 months. Is that?
I don't know the answer to that.
Okay, that's what I'd read, but haven't seen it.
We have a question. Is Base Aid planning on purchasing COVID tests or antibody tests? And how are you thinking about geographic locations within St. Louis where COVID-19 is concentrated and how that might affect the Shoals reopening?
I don't think we have any plans to purchase tests ourselves. We could refer people to places where they could get the testing done. As far as geography goes, yes, there are differences in geography, but I don't think when we make plans to reopen that we'll be making decisions based on geography. We'll want to make sure that our precautions are such that they would be safe regardless of where a person lives.
And it's probably worth mentioning at this point that one of the things we'll be going to discussing at the board is having an assessment of the airflow in the Shoal and seeing if we can do some things to improve that significantly so as to really mitigate the risk of aerosol spread.
Thank you. We have a question as well. What do you think about reopening a childcare facility in 3 weeks with assuming the proper precautions are being taken? Does anyone have any comments or?
Okay, well, I've been working on this very closely with a preschool in Alaska that our daughter's children are probably going to go to. And so that's a very complicated question, and it depends on your locality, because first and foremost, you have to follow the rules that are in place in your city, county, and state, and then the national CDC rules. There are extensive guidelines. But, and it doesn't exactly apply to Base Aid because we don't currently run a daycare. However, it's a challenge because children, depends on whether you have children in diapers who are toddlers, or if you have children who are 3 to 4 to 5 who are just before kindergarten. It's a different type of challenge, because the younger the child, the less social distancing they're going to be able to have. And, you know, basically it's a very complicated process. And if there was a more specific question about a specific daycare, I would say they really should download all of the local and national guidelines and pour through them to see, because they are quite complete. They tell you how do you need to clean, how do you need to handle nap time, how do you need to handle hand washing and sanitizing toys, it's quite complicated, how you need to handle personal protective equipment during diaper changes. It's really quite extensive. So there's a lot of information available online from the CDC and from the states and counties.
It requires
it requires hundreds of hours of going through that for an individual daycare, and in consultation with ideally an infectious disease doctor.
Okay. And it sounds. Sorry. Okay. We have a question, a clarification on the question about the Shoal buying tests and so on. I think the question is to hone in a little more, referring to requiring tests for entering the Shoal. So do people need to have the test, I think is the question, in order to come to Shoal?
Yeah, no, I don't think we're planning to require testing for entry into the Shoal.
Greg, you're aware, I'm sure there are very specific CDC guidelines on returning to work or returning to school, depending on if a person has no symptoms and tested positive, or if they had symptoms and tested positive, or if they had symptoms and didn't test positive but had a clinical diagnosis, and when their symptoms ended, and then whether they had or did not have 2 negative tests in a row. There are this is all available on the CDC website, and it does not require testing for everyone in those categories to be allowed back into their school or workplace. So I don't think that we would require that for Shoal also.
No, what we will require is that people basically agree that they're not having symptoms and that they haven't been exposed to somebody who has COVID or an illness that's suggestive of COVID.
Yeah,
we would like to come up with a pledge that participants say in a minion, would sign, like, I affirm that I have had, that I don't have this, this, and this, and I will observe these behaviors, and that I currently am okay. And then we're also planning to do temperature screening on entrance, and verbal screening of symptoms on entrance.
We have a question. What do you recommend about family members visiting? I assume from out of town. Would you recommend, are they able to get a test rather than quarantining for 2 weeks?
Maury, do you want to take a crack at that?
Yeah, that becomes complex, actually. You know, it's clear that at least initially, let's say if we get to the point where we're opening up the shul, or the numbers are getting larger, but certainly when we're going into the building, that initially it's going to be very difficult to incorporate individuals who have not pre-pledged and been screened in that fashion, that we're not going to have an open door policy. So we'll probably need to develop a mechanism for determining risk and getting people to assert that they'll, behave the way in which we would like them to behave. They're not going to go around hugging people. They're going to keep their distance. They're going to wear a mask. They're going to use sanitizer. That if we should be able to do that, it's just that we won't be ready when we first start. We'll need to try to get it just running smoothly without that. But if we're talking about a year, sure, we'll have to get to the point where family members can be included in this shul bubble that we'll be developing.
I don't, the question, if they want more clarification, I think there might also be a question, or it might also refer to just in general terms. I guess if you travel from out of town, do you need to quarantine for 2 weeks? Or could you in theory get a test when you get to town or something?
It'll depend on where
what we'd look for is that the person has been following very safe practices for at least 2 weeks before they come. And then we have to be concerned about the trip itself, because traveling poses dangers. We're still not comfortable with air traveling. So if a person comes on a plane, we would want them to be quarantined for a couple of weeks after they get here. If the person drives, that has the potential to be safer, but they're going to have to be very careful. If they have an overnight stay, that's potentially a problem. If they use bathrooms on the way, they're going to have to be very careful to be in and out quickly, to disinfect their hands. If they pump gas, they have to be very careful to disinfect their hands. And once again, the risk profile of the people they're coming to visit really needs to be taken into account as well.
Yeah, I think all of us have ended up, have needed to counsel individuals who have very compelling reasons to have to travel coming into town. Life goes on. I think there may have been one question about, dating, social situation, how, if you've met somebody, online and you've been, you've been Skyping for a while, at what point, what happens when you come to town? You have to quarantine for 2 weeks or not? And each situation is different depending on what the individual's done, where they're from, when they're, all those factors are very important. Again, if the environment changes and if the virus comes under control from an epidemiologic perspective, then many of these things become a little simpler. But for the foreseeable, couple of months, I think it's going to have to remain pretty stringent. Would you let someone coming in from out of town, I've had this question now twice, can they stay in your basement apartment? And in every case, we've seen that the 2 basement apartments that I asked them to look at, because they were unaware of their airflow, there were major intake, there were output and intake. So whoever was living down there in terms of aerosols would be spreading their aerosol throughout the entire home.
Yeah.
So issues like that come up with individuals that you don't know. And you have to plan for, if you don't know them, you have to plan for them being positive. I mean, that's what you plan for, that they're an asymptomatic shedder. And what can you do to mitigate the risk? And that's
I
how
think
we
one of
should
the
be
things
looking
that,
at it.
that people have to think about differently is when we talk about isolation, we've generally considered it geographic, like, okay, this room is, this bedroom with its own bathroom, that's an isolation room for my guest. And they're not going to come into the rest of the house. It has its own entrance and so forth. But it's actually the airflow that has to be isolated. And so you want any potential contaminated infectious person to be in an environment where the air is going to exit to the outside and fresh air from the outside is going to be come in, and it's not going to be being blown and distributed around into the rest of the house. So the isolation and quarantining has to be thought of as an airflow thing rather than just a physical place. Both, but.
We're obviously, we're struggling to figure out what to do for the next year and to mitigate the risk of infection, in particular for individuals who are somewhat higher risk. Again, 80% of the deaths have been in individuals over the age of 65. Many of the others have been individuals who are immunocompromised at a younger age. Relatively few, we hear about them, real profound tragedies. There's I don't know whether it's worth mentioning this evolving notion that there may be a relationship between the mechanism by which you get infected, whether it's your nose or whether it's aerosols into your lung, and the inoculum size, how much virus you're initially infected with, which may be playing some role in why some younger individuals do so poorly. But that's a hypothesis.
There are new studies that have just come out in the past week or two that show that if someone with COVID has gastrointestinal symptoms like diarrhea, the spread of the infection to household members is 4 times higher than if they did not have diarrhea. So it depends on where the most virus is that the person has. And so diarrhea is fairly infectious, especially because of the flushing plumes that occur whenever you flush a toilet.
Yeah. There was a major outbreak involving several hundred people in Wuhan in a building where they were all sheltering in their apartments. Their food was being delivered. They had that system in place in Wuhan fairly early on. But it turned out that there was one of the sewage stacks was under pressure and had a leak and was generating an aerosol. And their evaluation, their case tracing, implicated that in the spread throughout the building.
I do see a few more questions. I want to be mindful of time, so I will ask a couple of these questions that I think are interrelated in sorts, and then ask the rabbi to give some closing remarks so that. So we have a question from the chat. Okay, so a couple questions. One, how long are the minion restrictions going to last? Do you have any sense of that timing? And then perhaps thinking more broadly, this question came up in various forms. The high holiday, the Chagim are right around the corner. There's different life cycle events that happen. Maybe speaking briefly about next stages or how you evaluate maybe each stage of the reopening might be a good way to address it.
I think it's
we don't have enough.
very difficult, but we're going to have to watch what's going on in our own community and in the larger community. And we probably would wait, I'd say, at least 3 weeks after we implement one set of precautions before we go on to liberalizing. Maury, Tessa, do you want to add?
It'll depend on what's going on in the community.
We need to keep
whether
an
we're
eye.
seeing a spike, an upswing, or not.
I mean, nothing is written in stone either way yet. And so we just don't want to be jumping ahead of what's going on infectious disease-wise in the community. it's safer in many ways to go a little more slowly than what's happening, so that you have a buffer, so that you know that for the past 2 weeks there's been an uptick in hospitalizations or ventilator use or deaths, as opposed to jumping right in after guidelines are liberalized in less than 2 weeks. So,
but we are going to be working on this and thinking hard about it on an ongoing basis.
Right.
We'll develop, whatever mitigation strategies we can, anticipating that in fact things, have the possibility of getting better, and the goal is to open up as soon as it's prudent. But we really have no way of knowing how the reopening of the world around us, our society here in St. Louis, is going to be, and we don't know what's going to happen in New York for families who'll be visiting from there, or from Cleveland, or from San Francisco. We just don't. It's not predictable enough. We could probably come up with a couple of different scenarios. But I'm not even sure that we could put times on those.
And then I guess the question we'll end with, before I turn it over to the rabbi, is if all the CDC guidelines and so on have been reviewed and followed, is it safe enough in St. Louis? Referring to visiting, I think this was asked when we were talking about a different topic. Here, let me
just say something about that.
I'm sorry, Randy, did you want to clarify that question? Or childcare? Sorry. Okay. So basically, the guideline, going back to just hopefully relatively quickly, the childcare question about opening within a few weeks. If they've been following all the procedures and reading everything that you've mentioned, that you detailed, is it safe enough in St. Louis to reopen? I think is the.
Randy, I would say that the CDC and the local guidelines are minimum requirements, and what's more important, because of Pikuah Nefesh, in my view, and also because of this multi-inflammatory syndrome in children, which, although rare, is extremely severe. I think that it's preferable to be slower to reopen and allow the case following to develop, so that even if you are following all the guidelines, and you need to know what's happening in your community, because the more children that you have in your preschool, the more families you have, and the more those families are going to be interacting in the general greater community outside the Jewish community in the regular world in St. Louis. And so you have a lot of potential for introduction. So that's hard to know what the right answer is, but I would view it much like opening the indoor part of a shul, but maybe even a little riskier, because with children, they aren't going to be social distancing as much. Now there are some masks now that teachers can wear, where there are clear panels where children can still see their smiles, and that might be worth looking into. There are many things like that. Shoe covers to walk in, if outside people have to walk into the classroom for a few minutes. There are, indoor, outdoor shoes that people can wear. Everybody should have 2 pairs, one for outside and one that they wear in the classroom. There are lots of you can stagger shifts, but overall, the bottom line is I would watch very closely, and I would probably be slower rather than quicker to reopen, to allow something like at least 2 or 3 or more weeks to be sure that you don't miss an uptick in cases.
Wonderful, thank you. And thank you all for the questions. I think, if questions certainly will keep coming up, please, send them to the office, and I will be happy to pass them on. This session was recorded, so you can refer back to it, or if you had to miss parts of it. And before I give it to the rabbi, I just want to thank our doctors who have, I want to thank them personally. I'm non-muted one, but the help to the community, for their service, to everything. It's really a scary time we're living in, and so I just want to thank for this informative session and so on. And I will let the rabbi wrap up for us.
Thank you, Ruth. And I want to thank Ruth for moderating this town hall tonight and for collecting and organizing the questions. And I also would like to thank our 4 infectious disease experts who've been sharing their expertise with us tonight. And I want to thank everyone who joined this call, taking time out of your busy lives to give attention to this really important issue affecting our community and affecting our society. And I just want to close with some thoughts about going forward. As Maury alluded to, plans are in the works about guidelines for a limited and phased reopening, beginning potentially as soon as next week. And even as Ruth and I and Larry Friedman, our Shul president, and the 4 infectious disease specialists work on those plans, we're also continuing to run most of our regular programming, except for the things that happen on Shabbat. We're continuing to run via Zoom and other platforms, along with other initiatives that we have developed in response to this unique situation that we're in. And I want to say that both our ability to reopen successfully and our ability to continue to operate in a modified form until we're back to normal, whenever that happens, really depend on the participation and the cooperation of everyone in the community. And it's especially important in this regard to note that I think sometimes in the Orthodox world, we can think that the be-all, end-all of Jewish communal life is minyan. And while I started by talking about the importance of communal prayer, minyan is just one component of communal prayer. Coming together as a community could happen even in situations where there's not a minyan, where you have 9 Jewish men and however many Jewish women, where you have people gathering online and not physically in the same space. And there's a value in being together as a community in whatever ways we can be together. And I think it's important to remember that even if in the process of reopening, as is quite likely, we'll find ourselves in a situation where, at least in an intermediate stage, it's going to be hard to sometimes make a minyan, even when we are opening up again. Many of the most regular minyan goers on weekday mornings are people who are themselves in a high-risk group and unlikely to want to come to anything, even if it's outdoors, even if there's social distancing, even if everyone's wearing masks and adhering to all the guidelines and precautions. And it may be that we'll start up and we'll have in-person services and there won't be a minyan right away. And I want to say that although we do value, minyan is a value to be able to say Kaddish, to be able to say Kedusha and other specific prayers, there's a value in davening together in whatever way we can, even without the presence of a minyan. And I want us to bear that in mind, so that we don't think that it all depends on whether or not there's going to be a minyan. Even if there's 5 of us in the backyard of the shul, that's, I think, a worthwhile gathering. The other thing I want to say is that our Jewish life, our religious life, our spiritual life, and even our communal life don't depend on getting together to pray together in person. Most of Torah and mitzvot can be fulfilled in private. There's many, most of our Jewish lives can be fulfilled in private, even if more optimally we'd like to be together. And we thank God we live in an era where we have the technologies available to us to continue connecting through Zoom and email and social media and a myriad other ways. And I really want to encourage everyone on this call to find the ways it makes sense for you to be reaching out to one another and to the community more generally through these media. You can visit the Base 8 website to find the schedule and links to all our Zoom classes. There's a daily morning group that meets 6 mornings a week to recite Tehillim, say Misha Berachs for those in need of healing, and learn together. We have Friday Kabbalat Shabbat services prior to the onset of Shabbat on Zoom. Tomorrow night is Gokul night. You can find the link for order food from Gokul delivered, and then have Gokul night with your fellow Beis Abers on Zoom. The link for that is on the website as well. So I really want to encourage you to check the website for the schedule and links to all our Zoom activities.
Social event coming up. Right?
There's also, you can also join the ranks of Beis Abers who are volunteering to make phone calls to check in on one another, or join the Beis Abe Mowing Club. Information on that is in the schmooze, helping people with their lawn care during this time in a socially distant way. And finally, June 14th, we have our gala, which was rescheduled because of COVID, is taking place virtually on Zoom. June 14th. Again, information in the schmooze about how to join that. And lastly, I want to say I hope that people are continuing, those who have not been financially impacted by this virus will continue to support Beis Abe and other Jewish communal institutions here in St. Louis. For the most part, our expenses have not significantly decreased since the onset of the pandemic, but if anything, we're experiencing more requests for help from individuals in our own shul and in the larger community. And so please do continue supporting Beis Abe, the Federation, other Jewish communal institutions that really need your help at this time. And if we all participate in whatever ways we're able in the life of our community, through Zoom, through social media, through volunteering, through phone calls, financial support, my prayer is that Beis Abe will emerge not only intact at the end of this, but stronger than ever. Thank you all, and I wish you a safe and healthy and continually communally connected month ahead.
Rabbi, you're fantastic. That was an amazing Nobel laureate, Pulitzer Prize winning drasha. You have definitely risen to the occasion in St. Louis in a community that you only just met relatively recently.
And Mazel Tov.
When managed to
Thank you.
have a COVID-19, I guess, courtship and marriage. I mean, it's
yeah. If you want expert advice on a wedding, what to do and what not to do in planning a wedding and during COVID-19.
And Rabbi, you can probably attest to the unpredictability of human beings when it comes to distancing and all. I'm sure you.
Oh yeah.
Even in your.
I mean, I didn't want to lengthen the call, but I wanted to say, when you're talking about people adhering to guidelines, I've learned through my own experience, and some of you on the Zoom, watching people failing to adhere to the guidelines that have been very clearly articulated, in which they had affirmatively agreed to follow, even in a relatively small group. It's very hard to get people to follow guidelines, and that's clearly going to be something we have to build in. The rabbis talked about making a fence around the Torah because they understood the unpredictability of human behavior, and we'll also have to make fences around public safety.
And that's the best analogy, is like the fences around Torah and observance.
That's why 6 feet becomes 8 feet. It's a fence around the 6 feet.
Yeah. And why you wear a mask outside, even if you don't expect to encounter anyone, because somebody will walk up behind you and give you a hug.
Yeah.
Good.
Thank you very much. I hope everyone has a wonderful evening.
Right.
All right.
Thank you.
Good night.